Welcome to Mayo Clinic's ECG segment, Making Waves, continuing medical education podcast. Join us for a lively discussion on the latest and greatest in the field of electrocardiography. We'll discuss some of the exciting and innovative work happening at Mayo Clinic and beyond with the most brilliant minds in the space and provide valuable insights that can be directly applied to your practice. Welcome to Mayo Clinic's ECG segment, Making Waves. In this episode, we explore a transformative shift in cardiac device therapy, pacing and defibrillation without transvenous leads. While traditional cardiac devices have saved countless lives, they come with important risks, especially related to leads that traverse the transvenous system and enter the heart. And in recent years, leadless pacemakers and extravascular defibrillators have emerged as exciting alternatives that offer new options for select patients. Joining us again is Dr. Nicholas Tan, a cardiac electrophysiologist at Mayo Clinic in Rochester, Minnesota. Dr. Tan began his training in biomedical engineering at Johns Hopkins University and went on to earn his medical degree and master's in biomedical investigation from the Cleveland Clinic Lerner College of Medicine. He completed residency, cardiology, and cardiac electrophysiology fellowships at Mayo Clinic, and more recently completed a master's degree in medical device innovation at the University of Minnesota. His research focuses on pacing, defibrillation, catheter ablation, and device-based therapy innovation. Dr. Tan, we're glad to have you back, and thanks again for joining us.
Appreciate it. Thank you so much.
So let's start with the traditional approach. So what are some of those main risks that, associated with just transvenous pacing and defibrillation systems?
So to, again, kind of describe what transvenous device implants are, those are basically involves two components. One, your pacemaker or ICD generator, which is basically contains the battery as well as the computer circuit that controls and mediates pacing and defibrillation, and then the pacemaker or the ICD leads, and these traverse the venous system. So they utilize the venous system in order to enter the heart, and then from there the tips are implanted either into the right ventricle, the right atrium or right ventricle most of the time. Now the problem with this system as a whole is that the leads are the weak link for both pacing and defibrillation, in the sense that they are longer and they have a higher chance for mechanical trauma or damage, and they're also more liable to malfunction compared to the pacemaker, the ICD generator. So that's one major issue. The second major issue is that since the leads are in the blood vessel, they're within the bloodstream, and they're also within the heart, infections become a major concern. So if you develop a systemic infection, like say pneumonia, and that somehow gets into your bloodstream, then that can potentially seed into the pacemaker lead and then into your heart. And that is a serious medical issue that we often that we have to deal with. Doesn't happen all the time, but when it does, it becomes a big comorbidity that we have to navigate with our patients, with consequent high mortality as well.
Okay. And so I guess you can kind of see those risks in the infection, certainly being with one. What is leadless pacing? And I guess because you perform this, you're one of the few here at our institution that do. How is it generally more of an overarch? How do you perform it?
So again, conceptually, what leadless pacing is trying to do is we are trying to avoid having the pacemaker leads be the weak link of the pacing system. So what the engineers from various device companies have done is that they have compressed the pacing device as well as the battery into a single roughly bullet-shaped device that is self-contained. So by that, I mean it contains its own computer chip, so it can control and sense and pace as mediated by the body's intrinsic signals. And so the leadless pacemaker then can be positioned usually in the right ventricle And now there are also atrial devices, and they can also be made to talk to one another so they can communicate with each other to maintain atrial ventricular synchrony. In terms of how it is performed, then what we usually do is we have to again introduce the device into the heart somehow, and so we usually use one of the veins as a highway into the heart, and then we use a delivery catheter with the device in place, find the position that we want, release the device from the delivery catheter, and leave it be afterwards. And these devices have been built to have a battery life of about 10 years or so. And that's fairly similar to what the transvenous devices are.
So a lot of almost the circuitry sitting almost in that bullet shaped, um, almost a container that will sit in there with the battery. Similar, 10 years, quite amazing. Potentially also one in the atrial to preserve that AV synchrony, the top and lower chambers talking to each other, and minimizing that, that you said the weak link with the leads. So I guess how does the defibrillator without the leads work then? And how does that differ maybe from, you can talk about the traditional ICDs?
So again, the traditional ICDs involve having the ICD generator usually on the left side of the chest, sometimes on the right, and the ICD lead ends up being in the heart. So it's an intracardiac wire, if you will, that will act as the defibrillator coil that transmits that high energy shock towards the generator. So if you don't want to put a lead in the heart, you have to try and position it close to it. So one of the first transvenous lead-free systems, defibrillator systems, is is a system that's developed by Boston Scientific called the Subcutaneous ICD, and this involves tunneling a defibrillator lead above the rib cage, so underneath the skin above the rib cage, but relatively close to the chest. So again, this doesn't go into the bloodstream, it doesn't go into the vein, but this creates an electrical vector that will encompass the heart and allow for defibrillation to take place. And then more recently, people have looked into putting this electrode, again, not within a blood vessel, but underneath the sternum. So instead of putting the lead above the rib cage, this one actually goes underneath it. So from a proximity standpoint, this is actually closer to the heart than the subcutaneous lead. But again, this avoids the situation of having a lead traverse the venous system and having it be fixed to the heart itself.
When are you considering some of these leadless devices, whether pacemaker or defibrillators? What are the kind of the patient stereotypes that say, okay, these are, this is a good candidate? Because we know patient selection's, important in a lot of these things.
Yeah, so the circumstances would differ a little bit for pacing or defibrillation. So maybe we can talk about defibrillation first. So what you are trying to avoid for the long term is to have these defibrillator leads sit in the bloodstream, in the vein, and in the heart, especially in younger patients. So if you have someone who is at high risk for ventricular arrhythmias, but they are relatively young, and you want to try and avoid transvenous related complications such as infection or malfunction, especially if you anticipate that they'll live for many decades. A transvenous free defibrillation system will be very helpful in this regard. So if you can stay away from the vasculature, that will buy them time in terms of avoiding some of the major complications that can arise with transvenous leads. With leadless pacing, um, the main thing that you want to try and avoid is infection from transvenous devices. So the people I would often consider leadless pacing for patients who are at intrinsically high risk for infection, or who have already had an infection and you're trying to avoid the risk of a recurrent infection. The one of the major limitations to the leadless pacemakers right now is that the battery life is limited. So even though it's fairly equivalent to transvenous devices, for those when the battery runs out, you can at least replace the generator, and you don't have to replace the whole pacing system for say. With leadless pacing, you don't really have that option. Once the battery runs out, you have to implant a new device. And that's one of the major limitations of leadless pacing right now. So in someone who is relatively young and who's anticipated to live decades, this solution is probably not the most feasible compared to even standard transvenous pacing options.
The retrieval of that. Yeah, that is interesting. Yeah. Well, thank you. In today's episode, we explored another exciting shift, and Dr. Tan really leading the way here with these transvenous-free cardiac device therapy. He walked us through the rationale, the procedure, how to select that right patient for leadless pacemakers, extravascular defibrillators, and really giving us a look at what these innovations, how it's changing our field, long-term pacing, and ICD care. Dr. Tan, thank you again for joining us. We appreciate having you on, and we hope you'll join us again. Thanks for kind of leading this device therapy, both within our practice and really leading the way here. So thanks again for joining us, and please come back again.
Thanks so much. Appreciate it. Have a good day.
Thank you for joining us today. We invite you to share your thoughts and suggestions about the podcast at cveducation.mayo.edu. Be sure to subscribe to a Mayo Clinic Cardiovascular CME podcast on your favorite platform, and tune in every other week to explore today's most pressing electrocardiography topics with your colleagues at Mayo Clinic.
This has been a Mayo Clinic podcast.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Mark Moline, Wound Clinic Director of the Vascular Center at Mayo Clinic in Rochester, Minnesota. If today's episode gave you a fresh insight, imagine what a full course can do for your patients. Head to cveducationmayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses, all created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.